Well, it's been like, I don't know, a week and a half since I saw you guys last, or something like that. I hope you guys have been doing well and so far enjoying uh, the program so far. So I'm going to pick up a little bit. What we last talked about was sort of the hospital sector and all the different kinds of hospitals that are out there. And I'm going to pick up on that right now with probably the last piece of that, and that's profit status and what that sort of implies. So we'll go through that a little bit and then have some more time for discussion and whatnot. So, when we last left our intrepid heroes, we had talked about different kinds of hospitals, public versus private, safety net, critical access, academic types of care provided. And now we're going to tackle this issue of profit status. And so, profit status. So, just so that we're all on the same page, um, for profit institutions are those whose goal is strictly to make money for the owner, who then distributes that money to people that are shareholders. And that seems like it should be fairly self-evident, but I think it's worthwhile to lay that groundwork to begin with. And things that are not for profit, this is a little bit tricky and it gets a little bit confusing. But the term not for profit technically means the goal is to serve the members of the not for profit corporation. And so all money goes back into the operations. Not for profits can be tax exempt, but donations to them are not tax deductible. And that's different from nonprofits, whose goal is to serve the public good. These are things that are tax exempt, where the donations to them are tax deductible. Everything has to be publicly reportable. There's some gray area between not-for-profit and nonprofit. And so for most folks kind of lump those two things together. They're technically not the same. But for the sake of our discussions, we are going to lump them together. And a lot of our public institutions and our public hospitals are all truly nonprofits as opposed to not-for-profits. Now, don't blame me. I'm just the messenger here. It's ridiculous to me that those things are not the same, even though they sound very similar, but here we are. So some fast facts about U.S. hospitals, and you can see that 58% of them, and see here they make it unclear, non-government, not for profit, but that also means nonprofit, so it's irritating. And then you have state and local government hospitals, and then you have investor-owned for-profit hospitals. And the big point here is that, community hospitals are generally not-for-profit, public ones are non-profit, and investor-owned are for-profit. And that's about a quarter of the hospitals in the United States that are currently for-profit. And again, these terms are often used interchangeably, but we've seen enormous growth in that for-profit sector. And so, how does profit status impact function? In general, for nonprofit institutions, and in this case, I'm going to lump not-for-profit in there too, they are service oriented. So they typically will care for everyone based on need, but that also means that they might lose money. So they are not technically existing to make money. And the opposite of making money is losing money. So that may actually be a part of it. There are typically community members on their board. There's typically different levels of public reporting. So any of three-quarters of the hospitals in the United States, you should actually be able to look up what their budgets are, what their broad revenues are, what the taxes are that they pay, how much they pay employees, et cetera. It can be a little hard to find that information, but for the most part, most of it should be out there or freely available to you. And in general, then for nonprofits or not for profits, money goes back into the hospital's function. It doesn't go to sort of pad people's pockets. And long term, they are interested usually in the health of the community. Now, we'll talk in a little bit about when nonprofits behave not very much like nonprofits. And there will be lots of examples of that in just a little bit. But this is at least the fundamental premise. For profits, of course, are profit oriented. So their whole goal is to make money. Their goal isn't necessarily to take care of patients, but if they can take care of patients and make money, then that's what they want to do. And because they are for-profit institutions, they get taxed on that revenue that they make. And so those taxes can be a lot or a little, depending on how they report revenue and profits. But at least in general, they do get taxed. And by extension, they're always focused on the bottom line. They always use financial incentives as a motivator because the more that they can use financial incentives, the more they can keep revenue themselves and make money. They often have access to capital. So, what does that mean? That means that because they are a great big company that makes a lot of money, they're also very good to lend to. So if you're a bank, you like lending to these kinds of companies, especially if they demonstrate that they're good at making money, because you know that they're going to be a potentially a good borrower. So it's very easy for for-profit organizations to be able to borrow a lot more money in order to expand or do whatever it is they want. But the other side of this is if they're not making money, they can always just decide to close up shop. They don't have any public reporting. So they get all this money, they pay all these taxes, but we don't necessarily get to see any of that because they don't have to show that. That's the whole thing about for-profit companies. And this is one of the reasons why profiteering is such a problem in this country, you know, because there's no requisite reporting, right? Like you got a bunch of for-profit insurance companies in this country. They don't have to tell us exactly what their formulas are for denying people care, right? And so we are sure that there's a whole lot more bad things that happen, but because they don't have to tell us, it becomes very difficult for us to figure that out. Whereas when you're dealing with public or nonprofit organizations, it's much easier to sort of hold them to account because all that stuff has to be publicly available. Another thing that for-profit hospitals typically do is choose who they care for, and they make those choices based on what kind of insurance you have or what kind of diseases you have. And we mentioned the last time the Cancer Treatment Centers of America, which I have not had a chance to look up how they got bought up by City of Hope, but they were, they would choose to just focus on cancer patients, which they can do. And so, um, the extent of for-profit ownership across the healthcare sector is pretty broad. Most hospitals in general are not for-profit. But then you look at like dialysis centers, freestanding labs, urgent care, skilled nursing facilities. Most of that stuff is squarely in the for-profit sector. That means that somebody has figured out a way to make money offering dialysis, for instance, right? Or offering hospice care. And so we'll talk a little bit more about that as we go along. And the profits within the health sector are substantial, right? And this was 2021. Pharmaceuticals saw a significant amount of profits there. That was largely post-pandemic or during the pandemic. We saw, the rise of some novel drugs as well as vaccines. So that led to some pretty remarkable profits. But, honestly, there's just billions and billions of dollars out there that are to be had. And so, interestingly, if you're a doctor at a for-profit hospital, you tend to be somebody who takes more pharmaceutical money. And how do you know this? Well, there's actually a law that says that it must be reported for doctors that are paid by Medicare or Medicaid, which are federal programs, that they must be reporting how much money they get from, say, pharmaceutical companies. Now, I don't get any. So, like, you can look my name up on that list, and I've never gotten any money from anybody for doing this, for doing anything that I do, right? But the majority of doctors at investor-owned hospitals also take money from pharmaceutical companies. Now, what does that money go for? I mean, it could be any number of things, right? It could be educational programs, it could be travel, it could be, this is above and beyond people that are employed by those companies. These are doctors that are paid as sort of freelance associates to, you know, to talk about whatever. So for instance, and this is much less common than it used to be, but there used to be these drug dinners, and you could go and hear about the latest antibiotic given by like a leader in infectious diseases, and they would stand up there and tell you about it's been so long since I've been to one, but like Azactam, which was a combination of a beta lactamase inhibitor and God, I can't remember what else it was. But anyway, it was some newfangled drug that was supposed to be awesome. And so you could go hear like a literal expert, somebody who'd published, zillions of papers on a variety of things, get, I don't know what they get, 500, 1,000, 2,000 bucks to stand up there and essentially tell you about infections, and they'd get paid for by this drug company. And if I was an attendee, I'd get a free dinner out of it. And the dinners were nice. Like these were like at nice steak restaurants downtown, or like fancy places that me on my like resident or fellow budget would certainly never have the chance to eat at, right? So, I'm in LA for residency and Chicago for fellowship. Like, there's some good eats out there if you can get yourself to a drug dinner, right? And so that doesn't count for me to attend those, but for the docs that pay it, that get paid for those, that generally does. And so the point here is you've got a lot more docs that tend to do that. Now, is that bad? I don't know. There's certainly been plenty of studies suggesting that when you pay doctors for things like this, that tends to influence their prescribing practices. I didn't typically ever change my practice as much as a function of any of these dinners, but I did find them kind of interesting. I'm trying to think of the last one. I did actually go to one not too long ago. It wasn't a drug company, it was a testing company for a testing platform called Carius, which basically is a cell-free DNA diagnostic for sepsis. And I use Carius, and it was super informative for me to go to the thing and hear about some of the research that the ways that they're using the Carius tests. Um, it's so on occasion I'll go because it's good med ed for me as well. But for the most part, I don't really do that stuff anymore. And so you can see that the more sort of governmentalized you are, the less likely you are to go to that stuff. Especially if you're a federal employee, you've got to tell them anytime you go to these kinds of dinners as a function of your employment. So a lot of people just don't like to bother. If you look at CEO pay within the healthcare sector, again, 2020 was a good year for a range of companies. What was it that Regeneron made? Did they make remdesivir? I can't remember anymore. But I think they made one of the drugs that was big during COVID that made a whole lot of money. And I mean, like, wow, $450 million, like it's a stupid amount of money, right? Like, and and they'll make the argument that you have to pay CEOs this much money to stay competitive and to attract the best talent. Um, but it's hard to see how this hasn't gotten at least a little bit out of control. Especially when, you add this up and you're looking at, over $1 billion here of money that's not going to actually care for people, So I don't know. It does make one wonder if this is absolutely necessary. Certainly, this doesn't happen in any other country in the world other than ours. And then this is just within the health insurance industry, how much they're paying their various and sundry C-suites. It's just, tremendous amounts of money. So, I mentioned dialysis before. Let's talk a second about why dialysis itself is so ripe for being for profit. So, if you remember, Medicare came out in 1960, I want to say 64, but I think it was actually a little bit later, maybe 66 or 60. Oh, it was under Johnson. So maybe it was 68. And so that gave us the Medicare program and the Medicaid program. But early on, there was lobbying by interest groups, by people with dialysis who said, look, we've got all these patients that have end-stage kidney disease, and they're going to die. But if they could just get dialysis, they'd live and they could live for years. And dialysis had just kind of come out and been broadly available. And so they lobbied legislators at the federal level, and the legislators listened and said, okay, we will make anybody that has end stage renal disease requiring dialysis make you eligible for Medicare. That way, you know you'll always be able to have insurance. Because, of course, the problem is if you've got private insurance and your kidney disease gets worse and worse, and suddenly you need dialysis, dialysis is expensive, and you decide to change jobs. You go to that new job, and the new employer is like, hell no, I'm not going to cover you. You've got end stage renal disease. Your dialysis makes you super expensive for me. So the federal government heard that and said, okay, anybody with end-stage kidney disease, regardless of the age, is eligible for Medicare. I just thought about this last night because I admitted a guy who was in his 50s, and I was like, oh, that's interesting. He has Medicare. How does he have Medicare in his 50s? I said, oh, because he has dialysis. And so, I think that seems like a good thing, right? But what that really means is that every single dialysis patient has insurance to pay for 3 times a week visits. And so this means that if you want to set up shop as a dialysis company, every single one of those patients is going to pay, right? Because it's the federal government. The federal government always pays. It's Medicare. Medicare always pays. In fact, this is why like so many doctors accept Medicare because it's a reliable payer compared to these health insurance companies who can screw you around and be like delaying or prior authing or all this crap. Medicare is like, okay, we'll just pay because, federal government is not in the business of profits. They just pay. What a novel concept, right? So if you can set up a dialysis facility, staff it, get as many dialysis patients in there as you can, using that equipment as much as you can with the lowest number of staff that you can, like you can find a way to make good money doing this, especially if you can run economies of scale. So you have these gargantuan dialysis corporations in this country, like DaVita is one of them. Or I think there's another one. Is it Navian? I can't remember, but like really big companies that have figured out how to make money doing this. And so the end result, majority of dialysis in this country is delivered in a for-profit way. But the thing is, it's not 100%. And if you compared for-profit dialysis centers compared to nonprofit ones, this was a paper from a couple of years ago that was actually, I think Sam Dickman might have been a med student at the time, or at least an early resident. So he was in Boston working with Steffi Woolhandler and David Himmelstein. And basically, they found that the not-for-profit dialysis clinics did way better. One in the middle here is no difference between not-for-profit and for-profit. You can see that the vast majority of dialysis outcomes, when you compare the payment model of for-profit versus not-for-profit, it favors not-for-profit, leading them to estimate that just going to for-profit centers probably results in 3,800 excess deaths. If all those dialysis clinics were actually not-for-profit, people would get better care. Why? Because the incentive isn't to make money and get as many people through as possible. It's to just take care of people. Interestingly, when you look at the likelihood of offering profitable services like dialysis versus unprofitable services as a function of hospital ownership, again, for-profit hospitals much more likely to offer things that make a profit compared to government hospitals, which are much more likely to offer things or much less likely to offer some of those profitable services. And so, if you look at a for-profit hospital, they tend to deliver less high value care or more low value care. And so, if you estimate the volume of services that are considered to be of little value or low value compared to ones that are high value, for-profit hospitals do things that may not offer very much return. And you say, what is an example of that? So, for instance, and I'm no longer as well versed in what some of the examples are, but arthroscopic knee surgery was often considered to be a low value thing to do. Why? Because the outcomes in the long term for people that got arthroscopic knee surgery versus sham, where they just stuck a needle in a port and then took it back out, ended up not being different. And so people consider that sort of procedure not a high value procedure. And yet, you're a lot more likely to do that in a center that makes money for that, right? And so larger hospital systems, for-profit systems, are more likely to choose these profitable yet lower value services compared to teaching hospitals or places that focus more on primary care. For-profit hospitals, higher death rates. And again, this is a forest plot where the one in the middle is no difference. On the left side favors for-profit hospitals, on the right side favors not-for-profit. And this is effectively a meta-analysis comparing outcomes from a bunch of different studies. Literally 36 million, pooled patients pooled in this study, again, favors not-for-profit hospitals, suggesting that their death rates are higher. So, like, where do I want to go when I get sick? Not a for-profit hospital, because there's a greater likelihood that I'll die as a function of going there. Now, obviously, we know that there's lots that you have to control for here, right? Like what types of patients they are, what types of diseases they have, et cetera, et cetera, et cetera. But at least from a broad look, it certainly suggests that for-profit hospitals are inferior and they cost more, right? Because they're choosing profitable services. So they're going to do everything they can to bring more revenue in, whatever that looks like, even if it's things that are low value, even if it means focusing on the things with higher profit margin, right? So certain things like cancer chemo or certain procedures like cardiology procedures or GI procedures have a higher profit margin. So a for-profit hospital is going to be incentivized to try and do more of that to make more profits. And therefore, they're going to pull more revenue in. And that's what effectively this looks at, is the amount of spending that goes into for-profit hospitals. It's a lot higher. Of course, because they're focusing on profit, their administrative costs are higher. At an investor-owned hospital, almost 30% of their spending is just on admin compared to public hospitals, not-for-profit is less. And like Canada over there, they're only spending 12% on administration. So it's definitely a lot less. Um, if you have a for-profit hospital, they have higher readmission rates for pretty much every condition we look at. So there are a number of conditions now that are consistently looked at by the federal government, and readmission within 30 days is considered a penalty. It's a bad thing, right? Because if you got admitted for an MI or a pneumonia or for a bypass surgery or COPD or a joint replacement or heart failure, and you got discharged but then readmitted within 30 days, that suggests that maybe you didn't get great care in the first place, that they didn't do a very good job of taking care of you. They pushed you out too fast, and then you get readmitted. If you adjust for severity of illness, patients in the red were much more likely to be readmitted, and those are in for-profit hospitals compared to public hospitals in green or not nonprofit in yellow. And so, again, another marker of quality that's not so good. They also tend to avoid the things that are unprofitable, and that's the other side of choosing things that are profitable means also avoiding unprofitable things. Again, in red or for-profit hospitals, way less likely to offer HIV care. Almost none of them on the outpatient side would offer substance use disorder care or psychiatry or hospice or palliative care. These things are not necessarily as profitable. Now, there are profitable for-profit hospices out there, but at least within these hospitals, they're not necessarily pushing that, at least not in this paper. And this was a JAMA paper from 2022 that basically looked at services offered from these different kind of hospitals. And so, you know, like basically HIV doesn't make you money. So therefore, if you're a for-profit hospital, don't offer HIV care. This was a wild study. This looked at for-profits in Africa, and looked at how they manage dehydration. And in fact, the best approach to dehydration in general, or the most cost effective, is just oral rehydration, right? Not giving IVs. Um, For-profits were more likely to choose to give people the higher use, higher utilization IV therapies rather than oral rehydration therapy, or other things that were less effective. Which is just doesn't make a whole lot of sense to me. Also, like, who chooses to profit off of people in Africa? Like, that just seems gross. I mean, actually, everybody matters, so we shouldn't be profiting on anybody. But geez, Louise. Now you look at investor-owned nursing homes. And there's more and more of those around now. And if you look at investor owned versus nonprofit, you're much more likely on like JCO inspections to find deficiencies in those investor owned ones, like, overusing restraints, for instance, right? These kinds of things. So it's kind of no good, right? As I mentioned before, hospice is going more and more for profit. Didn't used to be a for profit industry at all, but now it's about three-quarters of independent hospice agencies are for profit. And they tend to avoid unprofitable patients. So they don't want the patients that are going to cost a lot of money at the end of life. And who would those be? Those would be patients that are still getting palliative chemo, patients that might need TPN, patients that get transfusions or tube feeds or any kind of palliative radiation. Those are therapies that can be offered to patients that are in hospice, but those patients, those for-profit hospices don't want them because that costs those for-profit hospices money, so they avoid them. Um, if you look at this is really interesting. People in high academic positions and their service on for-profit health corporation boards. So this would be like the dean of your medical school or the department chair of your department of medicine or just straight professors. They actually can get paid for serving on health corporation boards. They can get paid a lot of money. Like, I kind of had no idea about this and then realized that like this is totally out there. There's money out there when you rise in the academic ranks, particularly in these influential hospital systems in academic positions, and then they'll invite you to serve on their board and they pay you a bunch of money. Like, how can your decision making not be corrupted at least a little bit by your service on a board like this? Um, Now let's talk about nonprofit health systems. And you can see my fingers right. Um, all of these are companies that deliver healthcare under the nonprofit model. Possibly, they should be both serving the community and not making kind of crazy capital investments to pad their own pockets and pay high, CEO salaries. And yet, here we are. Like, these companies, this is publicly available because all of these are nonprofit, but you can see how much money that they're actually keeping. Now, Kaiser, this refers to the health insurance company and the hospitals. It's not actually who pays me. I get my physician group has an exclusive contract with that insurance company, and then they pay us a certain amount of money to take care of their patients. So we don't see those profits, or I don't. Um, but I can certainly see why it's kind of crazy how much Kaiser does. But I would also make an argument that um, pretty much every physician in the country, unless you work for a public hospital, gets paid for by an insurance company or by one of these large health systems that are ostensibly not for profit. And like, there's no way to work in the United States unless you work at the VA or a county hospital and not sort of participate in this. So I don't like it. I am absolutely continuing to fight against it because I believe that it's wrong. But like, I still need a job taking care of patients and helping people, which is what we're all in this business to do. So, I think that it's it's kind of crazy. But obviously Kaiser doesn't have any interest in me standing up here calling for the end of Kaiser Insurance. It probably limits my ability to rise too far within the leadership of my organization, and that's fine. I don't care. I am going to continue to fight this fight because this is the fight that I think is important. It's very interesting how much many of these health systems are now getting involved in sort of private equity, speculation, hedge fund, venture capital type investments, because these things are not going to benefit the community. These are the kinds of things that just result in return on investment. And again, you find more and more of this out there, billions and billions of dollars that's not going to patient care. It's just going to make more money. Um, so I think that there's a real problem in the way that we deliver healthcare as well. There's so much money there that's not actually going to directly benefit patients. This is a bunch of individuals from a bunch of sort of famous places, people that are deans, CEOs of big academic medical centers who are making a tremendous amount of money, either through shares or through salaries. And so some of these are people that I have an incredible amount of respect for. Probably my favorite is Lori Glimcher. She's like one of the most amazing immunologists, like ever to be an immunologist, is absolutely inspiring. And it makes me feel a little bit sad because like, well, like to what it now she's probably the lowest one on here, but still, like, and maybe this is part of the game as she sees it. I don't know. I've never had the opportunity to ask her, what it would be like, why this happens. But this is like MGH, Sloan Kettering, Mayo, Duke, University of Michigan, MIT, Yale, like all great places. So these are like nonprofits acting like for profits. And this, I think, is a fascinating quote. The notion that, you know, for nonprofits, I mean, cash reserves can grow. Charity care does not. It only costs more. So there's not really an incentive to expand the amount of charity care that you do. Basically, nonprofits are obliged to spend a certain amount of their money on the reinvesting in the community, so they don't ever exceed that. They pay the minimum amount that they can to meet their sort of tax exempt expectation and then keep all the rest of it, right? They never go above and beyond because that doesn't make them more reserves, right? There was an interesting article from 2020 called "How Nonprofit Hospitals Get Away with the Biggest Ripoff in America," partly by buying up physician practices, CEO salaries being crazy, overinflating charge master prices. And so, charge masters, we're going to have to talk a little bit about what the charge master is. And we'll get to that in a little bit. So, it's a worthwhile read if you're interested in looking at some of the where the money flows within this industry. But one of the things that we're seeing more and more of is this buying up of practices and frankly buying up of hospitals. And so this is just a 10-year period from 2005 to 2014. Fewer and fewer independent hospitals, more and more system-owned hospitals. And I watched this all happen when I was in Chicago. I was in Chicago from 2009 to 2019. And I watched my employer, the University of Chicago, fighting with Northwestern and Advocate. Those were the three big healthcare systems in Chicago, all snatching up all the suburban hospitals and even some of the urban hospitals, basically trying to buy them, bring them under their umbrella to create the economies of scale and also the referral pools. Because again, if University of Chicago in Hyde Park, Chicago, which is a pretty poor neighborhood, can have a bunch of rich people from the western suburbs, then they own that hospital. And then when those people need their cancer care and their GI care, they come to the main clinic. They all have great insurance. They all can pay. They all, boast about the wonderful care they got on Yelp or whatever. And that helps the University of Chicago diversify and make more money. And by diversify, we mean get richer people, whiter people, people of more affluent means to be their patients. And so that's a big part of what drives the snatching up, the consolidation of hospitals overall. It's also that, like, as hospitals get more and more stressed out, as Medicaid rates continue to not rise for reimbursement or Medicare rates not rise, these hospitals that live at the edge simply can't afford to keep their doors open anymore. And so they end up being primed for being bought out, or just simply shutting down. And again, that goes back to that concept I mentioned the last time, is that they're having to bear more and more risk. They're having to shoulder more and more cost, and they have declining revenues, and they just simply can't afford it. Um, You're also seeing these hospitals and health systems buying up primary care practice. And so you're seeing the gradual decline of the solo practice and the decline of the private medical group and the rise of them all being employed by hospitals or healthcare systems. And again, I remembered this when I was a med student at Case Western. The person that I did my family medicine outpatient rotation with was part of a larger health system. It wasn't just a private practice doc. They were part of, I think they were part of the Cleveland Clinic system or the University Hospital system or whatever. What does that gain them? It gains them, if you're a private practice, it gains you some access to resources. It gains you a referral base. You know who to refer somebody to within your system. If they need to see pulmonary, you're like, oh, I know one of 5 different pulmonologists that are part of this hospital system. You get to know them well and they'll take your patients. It also protects you a little bit from risk that that this bigger institution is going to support you even if you suddenly have a more complex patient population. It also means you have access to resources, which people totally needed during the pandemic. Here in Hawaii, if you had a private practice, particularly on a neighbor island, and you were told that you needed to provide PPE and N95 masks and gloves for all your employees, most of them were just like, screw it, we're shutting down. We can't afford to do that. We can't afford to buy a bunch of PPE so that we can stay open. It's going to cut into our ability to make any money. We just rather shut down. And so we lost so many private practices that weren't part of a health system because they simply did, oh my goodness, look at that dog. We simply did not have the capacity to make sure that they could keep their doors open. And so you know, I'm not saying it's the best thing or the worst thing, but the notion of going out there, hanging up your shingle and just being a doctor independently doesn't exist so much. Oh, we've got kitties too. My kitties were around, but they're not going to come up here. Um, so this is an example of one of the kinds of vertical integration that we're seeing. You've probably heard of United Health Group, but United Health Group also includes United Healthcare. That's the largest insurer in the nation. And this was data from a couple of years ago. 26 million privately insured patients, about 19 million patients in Medicare and Medicaid, 5 million privately insured around the world, about 3 million with Medicare Part D plans. They also own Optum. Optum is both Optum Health, which is a physician employer, largest employer of physicians in the nation, about 60,000 physicians serving 101 million patients. They also own Optum Insight, which is an analytics company that helps manage healthcare data and claims. And then, of course, there's Optum Rx, which is their PBM pharmacy benefit manager and mail order pharmacy. Like United Health Group owns the entire spectrum of delivery, right? All the things. And therefore, if you have United Healthcare Insurance, you better believe that they're only going to partner with the Optum Rx pharmacy benefit manager using the Optum Insight analytics, having you see doctors from Optum Healthcare. And that means that they can make as much money as they want. They're making money at every step of the way. And so if you look at their health insurance revenue, their private insurance revenue has been pretty steady in the billions of dollars there, going up a little bit. But look at how their Medicare revenue and Medicaid revenue has grown. United Healthcare is getting more and more into the Medicare and Medicaid markets, and that's that privatized Medicare, privatized Medicaid that we talked about because the government is such a good payer. The government just gives them a chunk of money per member per month for these Medicare and Medicaid patients and says, United, go forth and do what you will with that money. And United says, what do we want to do? We want to make profits. So let us make profits by providing as little care as we possibly can for these Medicare and Medicaid patients. And then we'll keep as much of the money as we can. They look at the government like a cash cow. This is the craziest kind of corporate welfare that, like, I don't know, I think I've ever seen. But obviously, I don't hang out in other industries, only in healthcare, but Lord have mercy, right? And so they're buying up home health businesses. You've got CVS, which is doing all the same stuff. Compared to United, you've got the CVS pharmacy, which is brick and mortar pharmacies. Caremark, that's their PBM. They've got their health insurer of Aetna. They've got their urgent clinics. All of these companies are doing this. They're uniting in this kind of vertical integration across the healthcare system. They're buying healthcare companies that have a lot of physicians. They've got virtual primary care, right? You've got these other companies that are getting in there. Walgreens is getting in there. CareCentrix, Amazon was trying to get in there. And I'm like, who tries to make money on primary care? Like, it's pretty hard to do, but they're going to try and figure out a way to do it, right? Um, One of my cats, one second. That was super distracting. One of my kids left some toys out, and then the cat started playing with them, and I was just only going to get irritated by the sound of toys rolling around the floor. Um, like I mentioned, Walgreens purchasing up home care companies, right? Like, remember that the only reason that they do this is because there's a profit opportunity. They don't give two shits about people's care. At least that's my belief. Now, people that work for them, like that's not to say that the people that work for these companies are uncaring. I think they all care, and I think they all want to do what's right for the patients that they take care of. So I'm not demonizing anybody that's employed here, but as a sort of global business model, these are opportunities that are first and foremost about making money. Um, and that's where I really have a problem with the whole thing. You got Walmart that started their own health insurance unit, and then they partnered with Oak Street Health, which many of you might have heard of. Oak Street Health CMO is a guy I know because he's a single payer person, and he firmly believes that what he's doing with Oak Street Health is helping people. And I'm like, yes, I believe that it's helping people too, but you're still using this model of we must make money doing this to, to incentivize things. And I just bothers me. And I know he feels like it's the solution, but I think it's still part of the problem. And then they've recently acquired a telehealth company, right? So these are all things that Walmart's trying to get into this. Now, this was an interesting one. This company called Risant Health. This was actually a new nonprofit started by Kaiser, who's my employer. But this was very interesting. This was Kaiser, the insurance company, not taking the docs along. So this pissed all of us off that are doctors at Kaiser because the whole Kaiser principle is founded on the tension between the physician group and the insurance company, where we, the physician group, just want to do what's right for patients, and then we have this ongoing dialogue with the insurance company. The insurance company basically did this because they don't want to work with the doctors anymore. They want to own the doctors and be able to tell the doctors what to do. So they bought this entire healthcare delivery system so that they can have that kind of leverage power over them that they don't have over us under the sort of traditional Kaiser Permanente model. And so Risant Health is a nonprofit accelerating value-based care. It's basically an insurance company owning hospitals and owning the doctors, owning the delivery system. And it and when their job is, even though they call themselves nonprofit, when their job is to figure out how to make money, it just makes me worry that they're going to avoid sick patients. They're going to avoid patients with social determinants of health that make them more expensive to care for. They're going to perpetuate the problems rather than really result in the solution. So I'm very skeptical of this model. So I mentioned this before, that we're moving more and more away from the independent hospital to the system affiliated one. And this is some more data on that from the American Hospital Association. Now, more than two-thirds are system affiliated. This is a list of hospitals in the Chicago area. And these were all independent community hospitals that closed over a 20-year period. These were all within the city. Oak Forest was technically just outside of the city. It was in Cook County, the county that Chicago's in, so we counted it here. And Blue Island is a near suburb on the south side. And so all of these hospitals closed. They didn't get bought up. They didn't merge with anybody else. They just closed because they couldn't afford to stay open anymore. Again, that concept of risk was being shifted to them. The reimbursements were too low. The patients were too sick, requiring too much more high cost care. And so all these hospitals closed. So that means that the number of hospitals in Chicago like has diminished substantially. And the ones that remain are either the county hospitals, and really there's just Cook County Hospital or Stroger. And then there's ones that are affiliated with Advocate, one that are affiliated with University of Chicago, and ones that are affiliated with Northwestern. There's very few left. And I'm not sure that that's a good thing. Mercy ended up not closing entirely, but they got bought up by a for-profit system, and now they only offer limited types of care. They were like a benchmark of community care on the near South Side. They were right in Chinatown. I used to moonlight there, and like half the patients were Chinese speaking, and about the other third were Spanish speaking, and like they were a good old-fashioned community hospital that no longer serves those populations anymore. And I think it's a real shame. This is rural hospital closures. So those are all in Chicago. But if you look at rural hospital closures, those continue um, to go up and down. Like during the pandemic, they were kept open by pandemic relief funding. So basically, there was a bunch of money injected into the economy that basically was like, please keep your hospitals open. If I haven't gotten new data for this, but I have no doubt that it's going up again. And with the Medicare, with the Budget Reconciliation Act, just passed last week, people are predicting that hundreds more are going to close. At which point you're not going to have any rural hospitals left, right? Like it's going to be really, really bad for those kinds of for people that live in those kinds of areas. And so, why are they at risk of closing? It's because of persistent financial challenges, depleted financial resources. And so let's talk a little bit more about this. So we've actually seen a rise in healthcare bankruptcy. So this is healthcare companies filing for bankruptcy because they simply can't keep things going. So why is this happening? Again, it becomes too hard to stay in private practice, and so a hospital will merge with another or simply close down altogether. Hospitals want their docs to be salaried. They don't want to have to negotiate with with private practices. So for instance, in Hawaii, everything is still a little bit backwards or behind the times. At one of the hospitals, there's still a private practice critical care group. This doesn't make any sense to me. Like there's a private practice critical care group, and they like have privileges at 3 or 4 different hospitals, and they just show up at those hospitals and provide critical care services for them. But they're not employed by the hospital. So they do all their own billing, they collect all their own revenue, they make money from the hospital because of those contracts, but they're not employed by the hospital. And it used to be that was the case for everything. Your infectious disease docs, private practice group, contracted by the hospital, not employed by the hospital. Anesthesia, cardiology, et cetera, et cetera. That was kind of the old way of things, but hospitals don't like that because they can't control those docs at all because those docs aren't salaried by them. So they have to renegotiate those contracts, and the hospitals need them. So that puts them in a position of some weakness when it comes to the negotiating table. Hospitals, want more patients with insurance to help cover those that don't. But if you can't do that, if you're stuck in the middle of an underprivileged neighborhood, you can't find patients with insurance to help cover those that don't have it or those that only have public insurance. This brings me back to the University of Chicago. And I was part of advocacy to bring a level 1 trauma center to the University of Chicago. And the University of Chicago did not want that level 1 trauma center. Why? Because they looked at the data. The trauma patients in Chicago, only 1 in 5 of them had private insurance. 35% of them had other, which typically means no insurance, right? About 17% with Medicaid, 10% with Medicare. You compare that to the majority of University of Chicago patients, prior to them becoming a level 1 trauma center. Look at that. Nearly, 39% had private insurance. That's great reimbursement. Another 36% had Medicare, a reliable reimburser, even if it's not as much, right? This is 3/4 of patients with reliable reimbursement compared to general trauma patients. University of Chicago did not want any part of those trauma patients. And so they didn't want to offer that service. And so, um, in the end, we fought and we got a level 1 trauma center open there, and that's a story of advocacy for a different time. But I felt like my role in that was to never demonize my employer, but rather say, "Hey, look, there's nobody else on the south side of Chicago that can offer the quality of care that we can for ICU, for neurosurgery, ENT, anesthesia, et cetera, et cetera." Of course, we have an obligation to serve the community. And there was a whole lot of amazing activism that went into that, and it ultimately worked, which was awesome. Um, Hospitals are also merging again to create pipelines for specialists. So you want more people that need colonoscopies and caths and cancer care, especially those because those reimburse well. So you buy up little hospitals. And the bottom line is again that hospitals are bearing more and more financial risk, and so this move to merge um, is a move to try and stay afloat. And frankly, I don't think we've protected our safety net and critical access hospitals very well. And this bill that just passed further guts safety net and critical access hospitals because it reduces the amount of revenue that goes to states to help keep those hospitals open. It reduces the share that's paid for rural hospitals in particular. So I think we can expect to see that this is actually going to only get worse. And of course, we've got this incredible complexity of reimbursement in our healthcare system. You've got a zillion different insurance companies and Medicare Advantage versus traditional Medicare. That complexity makes it harder and harder for a single institution to be able to navigate all that. So again, you create economies of scale, you merge, you become a great big company, and that's the only way that you can navigate this. And then the concept of the charge master. So let's talk for a second about that dissociation between price and cost. So the easiest example to think about is you need to get your appendix out. It ruptures acutely. And you could go to hospital A and that may happen and it may cost $5,000. And that's what the hospital would bill. And hospital B might bill 10,000 for that appendectomy. Hospital C might bill 15,000. And that's what's the charge master is sort of like the menu. It's sort of like this is how much we charge for these things. Now, we know that they never get paid that, right? They always negotiate with insurance companies for a reduced rate. So look at any bill that you've ever gotten for healthcare. And the easiest one is your dental bill. If you've ever looked at that, I hope you guys have dental insurance. But if you go to get your teeth cleaned and your dentist will charge $100, the insurance company will reimburse $50, and then they don't charge you that remaining 50. They might charge you a little bit. There'll be some portion of it that wasn't covered, but there's a negotiated rate in there. So that price of $100 or the 5,000 for the appendectomy, 10,000, whatever, these are made up numbers. And they're made up numbers by the system. Because think about it, if a hospital charges a larger made up number, then they can negotiate for a higher reimbursement price from that insurance company. So if hospital A is only charging 5,000 for appendectomies, and then they're going to negotiate for 50% of that, then the insurance company only pays them 2,500. But if you're the hospital, you're like, well, shoot, we should start charging 15,000 for appendectomies, and then maybe we'll get $7,000 or $8,000 per one done. But none of this has anything to do with how much it actually costs to do an appendectomy, how much it costs to pay the doctor, to pay the nurse, to pay the people that clean the scalpels, to pay the people that clean the room, to pay the anesthesiologist, to pay to keep the lights on in the hospital. None of those prices at all reflect the actual cost of the service that gets done. And so hospitals simply say, well, we'll just charge more. Insurance companies say, well, I guess we'll have to reimburse more. And then the insurance company says, I guess we'll have to raise your premiums so that we can pay more for the amount that we're going to pay for the negotiated rate that we have with the hospital. And then the hospital says, well, shoot, why don't we just raise the price even more? And this thing keeps happening and happening, and prices just go up and up and up. And so you look at these charge masters, and they have nothing to do with the actual cost. It's just a way that prices have been inflated. And so This concept of charge to reimbursement ratio was devised by this guy, Muhlstein, in 2013. And he said, on average, for Medicare patients, the charge to reimbursement was 3.77, meaning that hospitals charge almost 4 times more than they actually get reimbursed for Medicare. So let's come back to our $5,000 appendectomy. If that was being paid for by Medicare, that means that Medicare will reimburse 5,000 divided by 3.77, which is something like $1,400 or something like that, or $1,300. So that means that on average, the hospital's charging 5 grand, Medicare is reimbursing about 1,200. Now, what factors are associated with a high charge to reimbursement ratio? Being investor owned versus not for profit, being part of a healthcare system, having more beds. And so think about that. What if you had a charge to reimbursement ratio of 10? That means that on average for those patients, you would charge $10,000 but only be getting 1,000. But you're elevating that price as much as you possibly can, because what happens if you don't have Medicare? What happens if you're uninsured? You know what they charge you? $10,000, right? They charge you whatever that charge is, and then you get this bill that's crazy, right? So if you had insurance, the insurance company would only reimburse you whatever if it's 3.77, they'd only reimburse the $1,200 that Medicare reimburses. But if you don't have insurance or you have to pay out of pocket, you're going to get a bill for that $5,000 that appendectomy costed you. And so that's another place where they can get revenue. Now, that leads to, of course, medical bankruptcy and huge amounts of medical debt. And that's a conversation for another time also. But this is the people that charge a tremendous amount more than they get reimbursed are basically trying to make as much money as they possibly can. Factors associated with a low ratio: being rural, being academic, being government owned versus not for profit, or for profit, and having more Medicaid patients. Because you basically know you're not going to get any money, so you might as well just charge what you're going to get and have a low charge to reimbursement ratio. So this is sort of proof positive to me that hospitals and health systems engage in this price inflation war so that they can try and make more money. Does this concept make sense? It's a weird concept when I first learned about it, but it sort of makes sense when you think about how money flows within our healthcare system. So why does this matter? So again, it means that a hospital is potentially inflating prices. But more than that, each hospital's charge master is totally unique. So it's really impossible to compare prices from hospital A with their appendectomy that they're charging 5,000 for. We don't know why hospital B charges 10,000, right? Maybe it's because they do fewer appendectomies, so they don't have the same benefits of economies of scale, right? Or maybe it's because their doctors cost more for whatever reason, or they're in a place where the utilities are more expensive or the property tax is more. Who knows, right? Nobody knows. But these charge masters are unique, so you can't really compare prices from one place to another. But of course, if you're a patient, can you be all like, I'm gonna go to the hospital that charges me 5,000 versus 10,000 when my appendix is sitting there ruptured? No, you're gonna go to the closest place that you can to get the care that you need, because like, you are not in the business of shopping around when you are having an emergent problem, which is something that Kenneth Arrow taught us back in 1963, why healthcare can't really be a real free market, because there's information asymmetry and you don't have the benefit of choice, because it's kind of like your life or your death, right? America's Bitter Pill. I might have mentioned this the last time around, but this is a great book that looks into this whole thing. Stephen Brill wrote it. It grew up. It was also a Time article in the magazine Time from 2013, and he turned it into a whole book. And it's pretty fascinating. And it goes into all of this stuff that I just talked about. If you want to look at how the money flows, this is a great one to read. Now, hospitals that don't have a high charge to reimbursement ratio, why don't they? Because they're not trying to make money. I mean, they're trying to keep the doors open, they're trying to serve patients, but they're not trying to like gouge them. And so I think fundamentally this means that prices charged by hospitals, again, they bear no relationship to the expense associated with providing that service. So they can charge whatever they want and then negotiate reimbursement rates. I just don't think that's right. Hospitals close and merge, um, because of profit opportunities. That's the other thing that we're seeing, right? So look at the Hospital Corporation of America. This is that large for-profit chain, the largest employer of residents in the country. They can snap up multiple hospitals, use economies of scale to minimize staffing, staff with just residents who are as cheap as they can, and maximize profit. You can create regional hospital systems, creating a pipeline for referrals, and that makes sure that you get, again, more rich insured people. Um, and of course, when you have monopoly power over an area, you can further set prices. You charge whatever you want because there's no competition. Again, I don't believe in competition within healthcare markets, but when you do have a monopoly and the part of a healthcare delivery company, that does allow them to set whatever price they want. And so this was an article from not too long ago. Don't blame Medicare for rising medical bills, blame monopolies. Hospitals have insisted that they're charging the privately insured more to offset losses from Medicare patients, but a healthcare regulator blows the whistle on that myth. And so, to some, the biggest problem in the hospital sector is that shifting of risk onto hospitals and away from insurers. Different types of hospitals handle this differently as a function of their funding streams, private versus public, patient populations, academic affiliations. And I think we're on an ever, a spiral, right? Ever growing hospital systems that have regional monopoly power. And that is takes me to the top of the hour. Um, I think you're getting a separate talk about some of the more profiteering and private equity stuff that's out there. Um, but we're seeing that too, where private equity companies come in and buy, this problem we have on Maui right now. The emergency department doctors are not employed by the hospital. They're all employed by a private equity company. That group runs the ER there. And so, one, those docs don't know anything about the Hawaii community. They're just a bunch of people that aren't from here. And like, I actually really believe in sort of, I don't know, culturally competent medical care, that you want people of the community serving the community because they're going to understand the community's needs best. And we know that the community is going to appreciate the most. But more than that, that ER group is, you know, getting rid of as many docs as they can in favor of PAs and nurse practitioners. And they're not incentivizing good care. And so it's a mess when we get patients transferred from the Maui ER because I just don't think the care is very good or appropriate. But what can we do? Nothing, right? I mean, we could ask that hospital to contract instead with it to employ their own docs, but they decided that that cost them too much money. And so they'd rather provide substandard care with this private equity group. And at some point, this private equity group is going to decide they can't make any more money at it. And then they'll sell off the group to somebody else. And who knows what will happen. So it's been, it's creeping into all manners of healthcare delivery, and it's pretty awful. And if you ask me what the solution is, I have to say I don't know. I'm actually sort of personally wrestling with this a lot right now. This is Physicians for a National Health Program, and we've been all out here saying, hey, look, if we just have a single payer national health insurance, it's going to fix all our problems. But I'm not sure that it will, because that won't stop a lot of these actions of people trying to figure out still how to best game the system, how to find patients that reimburse the best, how to make money. And it makes me wonder, do we really need to get into the delivery system? Do we need to make all the hospitals nonprofit? Do we need to actually make them all government owned, akin to the national health system in the UK or the VA or the Indian Health Services? I don't know. And I'm struggling with this a lot because I think that a single payer is probably not enough. I think we have to do more to fix healthcare in this country. But I think that that's such a big lift. And so I feel like single payer is a necessary first step, but it's not and it used to be for me the destination, and I don't think that's it anymore. Because at a fundamental level, I got into this fight because I just don't believe in profiteering on the backs of people's sickness. I just don't think that's right. I believe everybody deserves health care, and I don't think that anybody should be profiteering and therefore making decisions based more on their bottom line and not anything other than the health outcomes of patients. So that's all I've got for you. Um, I'm opening it up for questions. Yes, there is.
Hi, I have two questions. My first question is, what are the requirements that a nonprofit hospital like have to meet to earn or retain that title? Because it seems a little strange to me that like for example, Ascension Health is technically nonprofit, but they can pay their CEO $13
Yeah,
million. And then I
right.
forget the other company that was mentioned in the hospital book, but they said they only gave 6 million in charities. So I'm like unsure how that works.
Yeah, so it's typically you have to provide some amount of what's called community benefit. And that is a mix of charity care or free care. It may also be reinvestment in the community. So investing in nonprofits or government institutions within the community that have a clear community benefit as well, and making sure that it's sort of like how individuals can give money to nonprofits and then deduct that from their taxes, right? So if I give money to a nonprofit organization like PNHP, then I can deduct that from my income and my tax amount goes down. So in effect, these not-for-profit hospitals have to meet a certain requirement, a certain amount of community benefit, which I think is indexed to what their total revenue is. So if the budget of the hospital is $100 million, then some percentage of that needs to go to community benefit, and that allows them to keep that nonprofit, and therefore we don't have to pay taxes status. That's the big benefit for them, because if they have to pay taxes, you're looking at, I don't know, 10, 15, 20% of that revenue having to get paid into tax coffers. And so they have found every way that they can to abuse this, right? And like, you would think that somebody should say, that is exorbitant CEO pay. You should stop that. But who's the person that's regulating all this? It's currently the IRS and the federal government, right? That regulates how this happens. And when you take the teeth out of institutions like the IRS, they can't come out there and tell you. They can say, hey, you shouldn't pay your CEOs that much. And they'll say, okay, and then keep doing it because there's no penalty for it, right? Because we have gutted the enforcement built into a lot of these federal organizations, um, that would be responsible for actually sort of policing this and making it not be so egregious. So they know that. So they're going to go ahead and do all of this and hope they get just a slap on the wrist later or a toothless penalty. It's when you dig into how much of this stuff that there are rules and yet there's no consequences, like the gutting of the federal government infrastructure has been really, really insidious. I mean, honestly, it's like the EPA has a bunch of rules, but if they're not going to penalize you, then companies will just go out there and pollute all they want, right? Like, if nobody's enforcing it, what difference does it make to have a rule? It seemed, and so at a fundamental level, they've all realized this. And, like one of the things that Biden did was expand funding for the IRS. One of the things that Trump did the first day he got into office was gut all that, right? So now you have more people that can go ahead and cheat on their taxes because they're not going to get audited because the IRS has a fraction of the budget that they had before. So they can't afford to audit anybody, whether it's these large hospital corporations or individual taxpayers. And so it's a deep and insidious way of finding ways to make money, by gutting the oversight. And that's a big part of what happens, which sucks. What was your second question?
Thank you. And my second question is like, what do you think is the best way for a well-intentioned, independent nonprofit hospital to survive, instead of like ultimately like either closing down or selling out their soul to a merger or takeover? Because in the hospital book, at least it seemed like there was like no other way out.
I know. I wish I had a good answer for that. I mean, the way the money flows right now is super messed up. And, Medicaid reimbursement is so low. And Medicare reimbursement isn't much better. And both Medicare and Medicaid are now partially privatized or nearly completely privatized. And you know what I mean? Like I don't like Medicare reimbursement rates for traditional Medicare have been held steady for like 30 years. Like prices continue to go up, whether or not they're artificially going up or it's just simply cost of, things, right? Just basic inflation. And yet reimbursement on the for Medicare hasn't kept pace with that. So like it's sort of not a wonder that everybody's starving right now. And so why hasn't that gone up? Because Congress has chosen not to do it. Now, you say, but Phil, you want a government run program overseen by Congress. How can you make sure that this won't happen? I fully agree, right? Like this requires more than just, continuation of the policies we have. It requires a complete rethinking of how we fund health and healthcare in this country. Um, but yeah, I wish I could suggest that there were some alternative, but I don't know that there is. Um, yeah, I think it's a real problem, and that means that the most vulnerable are again going to be the most hurt.
Thank you.
Other thoughts or questions?
Hi, Dr. Verhoef. I have a question. Have you felt personally in your career that while being involved, I mean, being a practicing physician, being involved in these healthcare organizations, something like Kaiser, you mentioned that, perhaps speaking on these topics, they don't maybe let you, or there's some pressure to not let you ascend to the top of their leadership. And in whatever form of leadership that you have had in your career and experience, has that been productive? Do you feel like them, whatever that force is keeping you down or not, would that have been more productive if you were able to be up there and advocating for these positions? Could you speak to that at all?
I think that's a really interesting question. Um, there's several different parts of this, right? There's my own sort of personal comfort. There's also sort of the power mapping that I have to do, looking at where the levers of power are and where I can make the biggest difference. And and then there's like, I don't know, laws on free speech, And so like when I was at the University of Chicago, I advocated for the University of Chicago to make changes, and I was pretty careful. I was careful not to throw them under the bus in the trauma center advocacy work. But I met people that did that were both on the faculty at the University of Chicago and um, or just employees, and they had different experiences. Not all of them good. And the way I looked at it is like I sort of decided I wouldn't get arrested. That was going to be one of the lines that I would draw. Not that there's anything wrong with getting arrested. I think it's if you're comfortable with it and you're good with it, totally fine. I felt like if I took myself out like that, that I'm not sure that I could have been able to help the movement understand some of the things that they needed because they didn't have any doctors in there. Like they didn't know what it actually meant to be a level one trauma center. So I was like, okay, guys, this is what it means to be a level one trauma center. This is what we really want. These, I felt like for me that was a line. But I also felt like if I'd ever heard from the University of Chicago that they wanted me to stop, then I would have looked at leaving. I'm not going to work for and it was good that it was a university that they're trying, particularly this is like 8 or 9 years ago. um Oh yeah. 8 or 9 years ago, when before all the weirdness that's happening now, where universities were like, yeah, free speech, especially the University of Chicago, which, in many ways can be a pretty conservative institution, but they're all a bunch of libertarians, at least in like some of the departments there. So they're like, yeah, free speech, free speech. So if I was like, hey, they're trying to suppress my free speech, like that was not going to fly, right? So I kind of had that in my mind that the second that came up, I knew that that was a pretty powerful lever for me to pull, and I would just leave because like I don't have to work there. I could work anywhere, and that was very much a personal decision that I made. Working for Kaiser is a little different. I've been more careful. I actually called the former president of Kaiser in Hawaii, who had sort of just retired, and a few years ago, I was like, hey, they want me to be president of PNHP. And he was like, I don't think you should do it. And I was like, okay, thanks for your opinion. And then I did it anyway, right? Because like I think that this is the fight that needs to be fought. But you're exactly right too, that like I also want to be at the table for some of this stuff. And I'm thinking about that now as I'm rising in like the ACP, American College of Physicians. I'm gunning to be our state's next ACP governor, which will get me at the table. I'm gunning to be the chair of the Committee on Drugs for the American Academy of Pediatrics, which will get me to the leadership table at a pretty high level. And so like working within those organizations, they're not employing me, um but I know they don't particularly want me to come out and be like single payer, but like am I going to do that when I'm in those positions at the table? You better believe it. Like I'm at least going to remind people that if we had a single payer system, boy, wouldn't it be a lot easier to navigate some of this stuff? And so that's a careful dance that I am sort of dancing for myself in my own professional career, to figure out how I can be in the places of power and make a difference. Um, but I think it also means I can't be too strident. I can't be out there getting arrested every other week. I can't be drawing attention to myself where the AAP is going to be like, oh, that guy's a firecracker. We don't want him in a position of power, because people aren't going to look at him as a leader. They're going to look at him as a radical. I mean, believe me, I'm all in on socialism. I'm pretty sure I'm just 100% anti-capitalist. But like, I have to be thought. Well, yeah, this is being recorded. That's fine. Go ahead and blast it out to whoever. I'm probably not going to run for public office. Although I ask my wife about it every now and again, and she usually discourages me because she's our state epidemiologist, and it would be weird to have an elected politician and somebody who's unelected in the same house. But I don't know. I keep thinking about it. So, those are things that I think about. Oh, it's fine. You don't have to edit it out. And I think it's one that you have to think about for yourself individually. Like, where's the place that you think you can make the most difference? And honestly, like, you don't have to be radical. Like there's so many fights to be fought out there, and like you need to push yourself as far as your comfort level is. But like, I don't know. I got two kids. I live in ostensibly the most expensive state in the world, right? Like I cannot lose my job because we cannot afford to stay here, Like it's so I have to and I want to serve the people of Hawaii. Like it's an incredible place, and it's a place that totally needs me. So like those, you have to figure out what that balance looks like. And you may come out of this and you may sort of decide that the fight for you is one that isn't quite I don't know. I feel like all the fights are big now, right? But like, I don't know, fighting for immunizations shouldn't be that controversial. Fighting for reproductive justice shouldn't be that controversial. Like fighting for transgender care shouldn't be that controversial. And yet all of these are becoming controversial. There used to be things that didn't seem like they were quite that controversial, but now everything's one or the other, and you're either a radical or you're not. So I don't know. Pick whatever fight is the one that you want to get into. I've enjoyed this fight because I've learned about so much of our system. But you don't have to learn about everything, right? I had a ex-girlfriend whose mom like led Planned Parenthood in San Diego for a long time. That was the fight that she wanted to fight. She was an OBGYN, and she was going to die on the hill of women deserve, reproductive health access. They deserve abortion care. They deserve screening. They deserve all the things that Planned Parenthood provides. And she knew that that would put her in harm's way at some level, but she was willing to do it. There's fights for all of us out there. I just think we have to be willing to fight for something, whatever it is. That actually reminds me, since like half of you are from New Jersey, one of my friends has decided she's going to run for Congress in New Jersey. She's a doctor. You should look her up. Her name is Tina Shah, Shah. She was 2 or 3 years behind me in critical care fellowship, and she also worked for the federal government in that as a White House. What's that program? I can't remember, but it's real cool. They get you to go hang out in the White House, basically. And she did that in 2016. So she watched the transition from Obama into Trump. Um, She's great. She's a doctor. She does not support single payer. She said that to me on LinkedIn just a couple of days ago, and I haven't had the chance to engage her in that argument. She believes in incremental and politically feasible solutions. I think we got to blow the whole system up, but that's okay. I also feel like if you have docs who are willing to go out there and run, I think we should support them. I know that she's a good egg. So if you guys can vote for her, you should. You should also, if you happen to be from South Carolina, vote for Annie Andrews, who is running for the Senate to unseat Lindsey Graham. She's amazing. She's a pediatrician, and I got to meet her last month or a couple months ago. Like another inspiring physician who has had it with the system. I asked her if she was a single payer supporter too, and she didn't give me a straight answer. So I think she is, as a pediatrician, she certainly supports Medicaid, and children, and CHIP and children's health. I think she supports universal health care, but is she going to go to the hill on it and die on that hill like Warren and Sanders in the Senate, or like, Jayapal and Dingell and, AOC and some of the other people that are on the House single payer bill? I don't know if she will, but would I vote for her if I had the chance? Boy, damn right, because she's got her head on straight and she's a doctor, running for government. So um, all of those people are making these same kinds of calculations and trying to think where can they make the biggest impact in this system.
Um, Thank you so much. I love listening to you talk. I really enjoy your opinions and the emotion you put behind everything. So thank you a lot. I wanted to ask, we talked a little bit about how the AMA is really pushing back against single payer and when you talk to doctors personally, like that you're working with, or have like a cordial relationship with, and you mentioned single payer, what is the number one reason that they say that they're against it?
Oh, so glad you asked. Um, it's a couple of things. The first is, well, I don't think Medicare is all that great. Like Medicare is okay, but it doesn't reimburse as well as private insurance. And also, Medicare has a lot of administrative crap that comes with it. So these things called MIPS and MACRA and value-based things that they're trying to build in to incentivize value-based care, whatever that means. And these were misguided ideas, a lot of which came out of CMMI, the Centers for Medicare and Medicaid Innovation, where they thought, hey, this will for sure make things better and save everybody money, but really it just adds administrative burden. And so, even though the vast majority of physicians accept Medicare, they also see a lot of the flaws in Medicare and they don't like it. The other thing that, frankly, most of them are worried about is we're all going to take a pay cut because look at how it is in other countries. It's going to suck. Now, um, so what that really tells me is that we have not told them that when we talk about single payer, we're talking about improved and expanded Medicare for all. So it's not just Medicare for everybody in the system that we know, it's improved in so many ways. We would abolish all of the administrative nonsense that exists. We might abolish all fee for service processing. We'd abolish, you know, any of the restrictions that are often placed upon docs. And because of that, and because we would also be abolishing private insurance, you would be abolishing the need to have a large staff that needs to navigate all of this different complexity that exists. So we haven't been able to sell them on the improved part of things. We also haven't been able to sell them on the how will we pay doctors and hospitals part of things, right? Because without question, a single payer will result in way more money in the pockets of primary care docs and perhaps a little bit less in the pockets of the neurosurgeon and the cardiothoracic surgeon and the plastic surgeon, who will go from making $1 million a year to maybe making 700,000 a year, right? And so it's you know, that's $300,000 that could be distributed among primary care doctors to make their lives demonstrably better because they're starting at so much less, right? And so we haven't sold them on how all of that's going to work. And until we can convince docs of that, and the AMA is going to, you know, remember that the AMA serves the interests more of the subspecialists and the high income docs than it does primary care docs. But that's also why, if you look at the physician organizations outside the AMA that support single payer, who is it? The ACP, that's primary care internists. The AAFP, that's the family docs. They love it. The APA, the American Psychiatric Association, they got a thriving single payer group. The pediatricians don't as much, but it's because they don't feel the effects of this as much because 50% of kids have Medicaid. So the pediatricians don't actually see uninsurance as the big problem. They want to protect Medicaid tooth and nail, but but there's not actually that many uninsured kids in this country. So they haven't been as good about this fight. But you know who hates it? The surgeons, the radiologists, the orthopods, the neurosurgeons. Like in PNHP, I know one neurosurgeon and he's real cool. But like, I'm like, man, you're like the only one. And he's like, yeah, no, I talk to neurosurgeons and I can convince them, but like only a neurosurgeon could convince another neurosurgeon that single payer is a good idea. And so we need to get more of those guys involved. And that's hard, you know? And so that's that's I think I don't know. One of the biggest barriers that docs raise to us is, you know, I'm going to lose money or Medicare kind of sucks and I don't want Medicare for all. And then maybe there's just fear of the unknown, you know, in spite of the fact that Medicare functions where 98 cents of every dollar taken in goes out to pay for healthcare. They still assume that it's going to be a hot ass mess when, you know, when it actually gets rolled out. I can't blame them, right? It's a crazy idea to suddenly, presumably, expand taxes by a lot, even though that would be less revenue than we all pay in insurance premiums, and to suddenly expand Medicare from 50 million people to 350 million people, knowing that that's also going to include Medicaid, so we could dismantle that, but also all those people on private insurance. So it's like, I get it, but like I also believe we have to do it, so I'm going to keep fighting to try, you know?
Sorry, I have a follow-up question, but if somebody wants to ask something in the meantime. We talk about how a lot of people want to go into specialties because they're higher paying because of the higher cost of medical education in general, especially now with the big beautiful bill.
Yeah. Gutting
Um,
student loans, man.
yeah,
Yeah.
yeah. So how do you think there's a future where we can decrease the cost of medical education?
So this gets at the other thing that I'm really I'm struggling with single payer movement right now. And because this is another example of where just reforming the insurance system is not enough. We have to reform the medical education system. We have to reform like and And so, like prior iterations of the single payer bills have alluded to, yeah, we'll come up with some system for changing medical education, or everybody can do like a health core or Mayor Health type thing. But like, I don't know. I it needs reforming, and I'm not sure we should actually tack that into the single payer bill. I actually think there should be a slate of different things that address medical bankruptcy, that address medical education, that address you know, the delivery of healthcare, not just the insurance for it. Like there's all these different parts of this whole thing, and the insurance part is just one part of it. And I used to again, this is me having an evolution here. Like I used to think, wow, let's just start with the insurance thing and we can fix all the other stuff later. I don't know. I'm not sure I believe that anymore. And so one of the things that I'm bringing to PNHP, bringing up more in our discussions is how do we think about all this other stuff, you know, and what is that? Does a national health program, is a national health program not just national health insurance, but actually it includes public health infrastructure, medical education. It includes healthcare delivery. Maybe that's what a national health program is. So I'm wading into weird places here. And I don't know what the end result's going to be. And I'll keep fighting with PNHP because I've been doing it for a long time. But I'm kind of hoping to move us a little bit more into this more global view of what it all is and calling it out separately from the single payer. Because I don't think the single payer is enough.